So let me raise what seems to me to be somewhat of a conundrum, right? Which is I talk to specialists and subspecialists like yourselves, and there's a tremendous amount of concern about the patient not being treated as a patient and their goals not being adjusted to. And yet when I go to any of the fancy buildings in Washington with three-letter acronyms that want to measure healthcare and so on, everything comes back to how closely did you follow the guideline, right? And so the plans, the payers, many of whom have adopted either the GOLD or the COPD Foundation treatment guidelines because that's what they have to fall back on and that's what they're being pushed to use. So I'm going to ask you, Maria, how you're using those algorithms and then where we need to follow the algorithms for a basic patient and when we know to veer away from them. Because we're having this sort of headbutting between personalizing therapy and standardizing therapy, and both are actually quite strong movements.
And also the payer is usually not in the role of practicing medicine. So, and this may even tie to the formulary, what drugs are available and how onerous, we create barriers in terms of using certain drugs or not. But I think the point is a good one. I think we tend to, as a payer, this is a disease that has incredible importance in terms of the implications for total cost of care. So for the most part, wanting to have access to agents and classes of agents that, per the guidelines, should be used. And if anything, generics are on the lowest tier, so we want patients to use them. But to the extent that there's clinical inertia, that's where hopefully data helps to assist in closing gaps in care or being able to provide meaningful, what I call meaningful and actionable data to clinicians so that they could see that just because they wrote the prescription, the patient never picked it up, or that they're using the wrong combinations or more, rescue inhalers, et cetera. So the payer is in an incredible position with data to be able to look at not only variations in care, but also gaps in care that hopefully have a meaningful impact on how we can not only personalize, but perhaps keep people out of the hospital or out of the ER.
So let me just follow up on that, Maria, because I find it very interesting. Because the part of the problem, as we mentioned before, is that patients with chronic diseases like COPD have so many other comorbid conditions. Right. So it's not at all unusual for a patient with COPD to have 5, 6, 7 other conditions and to be on 10 to 15 different medications. Anyone who believes that those patients take 10 or 15 different medicines are drinking something. I mean, it just doesn't happen. Even if you've got a drug plan, once you start adding 5, 10, 15 different drugs with your copays, you're talking about hundreds and hundreds of dollars a month. It's an impact with all of the things we do in medicine, but it's particularly an impact in patients who have COPD because of what Frank said from the beginning, that people frequently will cut back on their activity level. It's the reason why there's a lot of data suggesting that even though we have medicines that oftentimes can help, that only 30% of people will refill a prescription for many of these medicines because there's a cost issue as you start adding these 15 different drugs. It's one of the major differences between asthma, for example, and COPD. There are many, but most young asthmatics just have asthma. Most COPD patients, as they go along, have multiple other issues with multiple other medicines. I don't have a simple answer to that, but it is a problem.
So let me ask you a question about trying to pull this together, right? So, we as payers and a lot of provider organizations spend their time, bringing the GOLD guidelines, as an example, out to their primary care docs and so on. When do you deviate from those, and is it based on exacerbation? Is it based on symptom? Is it based patient to patient? How do you decide when it's the deviation from the algorithm is justified?
So one good thing about the COPD-based guidelines, both with the COPD Foundation that Byron has a heavy hand in and the GOLD guidelines, is they actually do have components of personalized medicine in those. So they do acknowledge one size doesn't fit all. They're also not just based on the traditional definer of disease severity, FEV1. They acknowledge symptoms and exacerbation frequency, and they stratify different therapies based on those. And so those guidelines do allow for some granularity. As specialists, we don't worship the guidelines because we recognize there's even more granularity and make decisions that, I mean, I don't know when I follow or I don't follow the guidelines because as a specialist, I think the guidelines are thoughtful. They help guide therapy, but I feel that there's needs to be more flexibility, and so I really couldn't tell you when I don't make a decision to follow or not to follow the guidelines. I treat the patient in front of me. The reality is probably the majority of times my treatment is consistent with the guidelines, but there are some variations, I think, as a specialist.
I think that what Frank said is probably true with most of us. I think the problem is complicated because, for example, if you look at GOLD, and you could make a strong argument that GOLD is the most important program in the COPD world over the last several decades. They deserve a tremendous amount of credit for moving away from the FEV1 alone to include issues like exacerbations and symptoms. I think they provide a wealth of information. Their impact, however, and I'd be interested in what Frank has to say, I think their impact has predominantly been on the academic world, on clinical research trials in academic centers, with much less impact in the primary care world, where I suspect that most people don't know what GOLD is. And that's problematic when most of your people live in primary care. And I know we're going to be talking more about the medications that are available, and there are medicines that are available, but I think the data is suggesting that in the primary care world, most of these people are being treated with a combination of long-acting beta agonists and inhaled corticosteroids as if they have a variation of asthma, and that's probably not the best approach.